Welcome, everybody. As I mentioned earlier, my name is Jillian Tallman, and I am a communications officer here at McMaster University, and I work on Pain HQ. As you may know, it is a online patient-focused resource that is dedicated to neuropathic pain. So thank you for joining us today for our expert webinar. At the end of today's webinar, there will be a chance for some Q&A with Dr. Buckley. As well, you'll be prompted to fill out an evaluation at the end, which you can use to provide us with some valuable feedback that we can use to decide topics for future webinars, what you liked, what you didn't like. It's great to have your feedback on what you'd like to see in the future. And with that, I will turn it over to Dr. Anthony Levinson.
Thank you very much, Jill. We are delighted to have with us today Dr. Norm Buckley, Scientific Director of the DeGroote Pain Clinic at McMaster University and Director of the Michael G. DeGroote National Pain Center housed here at McMaster. Dr. Buckley is an anesthesiologist, and he has a particular interest in the issue of pain, both acute and chronic pain. He's been extensively involved in the development and organization of the acute postoperative pain service for adult and pediatric patients, as well as the pediatric sedation services. His clinical practice is divided between chronic pain management and anesthesia at McMaster University, with a particular interest in pediatric practice as well. The mission of the Michael G. DeGroote Institute for Pain Research and Care is to better understand the underlying mechanisms of chronic pain in order to develop better prevention, diagnosis, and treatment strategies. As director of the Michael G. DeGroote National Pain Center, Dr. Buckley's work focuses on improving the management of chronic pain through the dissemination or spread of best practice information and guidelines for managing pain. Dr. Buckley has also been working with us on the DeGroote Pain HQ website to help bring high-quality health info to people on the topic of nerve pain or neuropathic pain. Today we're really fortunate to have Dr. Buckley speak to us about interventional techniques for neuropathic pain management. So thank you very much, and over to you, Dr. Buckley.
Thanks very much, Anthony and Jill. It's a pleasure to be here today, and we'll work our way through some discussion of a variety of interventional techniques. The first thing that I would like to just work on a little bit here is making the slide work. My apologies. I know it said that the control had come to me, but it's not advancing right. So one of the things we'll do is the first disclosure. I am a pain clinician. I provide interventional pain care, and that does color my judgment a little bit. It means that I believe that what I do is useful, although I try to maintain a critical position about making sure that I only do things that are, on average, helpful for people. I don't have any affiliations with companies who manufacture or sell products to do with interventional pain care, so I'm not conflicted from a financial standpoint. I do periodically get speakers fees for giving talks at various places, and the speakers fees have come from pharmaceutical companies, and I've also received research funding here at the Institute, although that allows research to be carried out. It doesn't benefit me personally. So maybe we could advance to the next slide. The discussion of interventional techniques refers to injections of medication, the insertion of devices to deliver medication, or the use of nerve stimulation techniques in the treatment of pain. Next slide. So one of the things we have to, just to keep it in perspective, pain is, and anyone who suffers from chronic pain is well aware of this, pain is a multidimensional problem. There is typically a physiological injury that occurs, maybe the result of surgery, a motor vehicle accident, some other sort of trauma or accident, Sometimes a physiological injury is a function of a disease like diabetes or an infection. But it occurs to a person, and that person has some underlying characteristics, both their psychological condition. People may or may not have mood disorders, depression, anxiety that exist before the pain occurs, before the injury occurs. They have a certain style of learning, they have expectations, and they've had previous experience sometimes with injuries and surgery and the implications. And then it also occurs in a social setting. So the impact of pain goes beyond the physiological injury, but we're going to focus mostly today on aspects of physiology because that's the nature of the interventional approach, but it often needs to be done in the context of managing other things. Pain itself is a subjective state. That means that all kidding aside, if somebody comes into my clinic and says, "Doc, is my pain all in my head?" In fact, it is, because you have to be awake and alert to interpret pain. You have a sensation, but it's interpreted by you as pain. Some people have a given sensation and they so-called manage it or put up with it, or they do things to make it less troublesome for them. In some people, the same kind of injury is overwhelming and it brings their whole life to a halt. And that sometimes that becomes what we call the chronic pain syndrome. But at the end of it, it's a subjective state, and we can try to modify the physiological factors that go into creating some of that subjective state. Next slide, please. So this is just a picture of some of the physiology behind why we try to do interventional techniques. So if you look over on the left-hand side of the slide, number one, something happens to you. There's a pain stimulus. It usually happens with an injury. So you get trauma, or you get a burn, or you get some chemical injury, or you twist something, or you break a bone. And the pain stimulus comes in from the skin, from the bone, from the joint, along nerves, into what's called the dorsal root ganglion, just outside the spinal cord, and then into the spinal cord where it's perceived. Information goes up through number 3, the so-called ascending pathways that take it up to the brain. It arrives in the brain where you interpret it, you identify it as pain, and then you go through a process of trying to inhibit the pain. So your body has what are called descending pathways, which try to limit the amount of pain that you experience. And over time, you can exhaust these, and that may lead to development of more and more chronic pain. There's another thing that happens back at number 2 there, the synapse. If you keep experiencing this peripheral stimulus, this pain stimulus, it may lead to what's called central nervous system wind-up or excitation, so that it gets to the point where anything that touches you becomes painful. Even though the original injury might have healed, you continue to feel pain because your nervous system has now started to interpret all incoming information as painful. So that leads to some of the problems we see where people seem to have healed from an original injury, but now they continue to have pain. Next slide, please. So who should have an interventional kind of treatment for pain? Well, first of all, it needs to be someone where their distribution of pain corresponds to an identifiable nerve distribution. So that's very true for, we'll talk about some peripheral nerve injections that might be useful for pain. The person who might need a more intense intervention, say what's called a radiofrequency rhizotomy, which basically is a kind of an electrical burning of a nerve, that may be something if you have a good response to a nerve injection, but it doesn't last very long. You may get some drug delivery systems where we deliver drug directly into this fluid around the spinal cord to enhance its effect while minimizing side effects. There are some very specific clinical problems where we may choose to do interventional techniques like inserting a spinal cord stimulator, for example. And so those are the clinical situations where we might set out to do it. It has to be done in the context of a discussion with the patient about how their pain affects them, how serious is it. If you're going to do an injection, injections always have some kind of risk. Some people will not tolerate needles, for example. Those would be bad people to do injections on. They need to accept the idea of the approach, and we need to have a pretty clear discussion with them about what the potential benefit is and also what the potential side effects or the things that can go wrong that might make it more of a problem than a benefit for them. And the other thing is that there shouldn't be contraindications. A contraindication to an interventional treatment might be if they're on a blood thinner, for example, for a dangerous cardiac disease or to prevent stroke. Some of the blood thinners will cause bleeding, which could be dangerous if you do an injection around the spinal cord and the patient's on a blood thinner. They may bleed into the spinal cord and cause nerve injury or even paralysis. People who have ongoing infections, so if you have infected skin at the site of the injection, then we won't do an injection. The infection needs to be cleared up. Or people sometimes where it's just technically impossible to carry out the injection. Next slide, please. There's a fair bit of guidance available, although there's still a great deal of work to be done in clarifying exactly when interventional techniques should be used and what sort of patient should receive them. And to some extent, there's some discussion about what kind of training physicians need in order to be safe at providing these. One of the groups that has developed a set of guidelines for how we should use interventional pain treatments is the Neuropathic Pain Special Interest Group of the Canadian Pain Society. A few years ago, they published this guideline called the Evidence-Based Guideline for Neuropathic Pain Interventional Treatments for use of spinal cord stimulation, intravenous infusions, epidural injections, and nerve blocks. And I'll refer to a couple of those specific guidelines a bit later on. It's a useful document for physicians to try to give them some guidance about how best to make use of limited resources. There's no point giving treatments that aren't helpful for patients. On the other hand, sometimes you try things because you think it might work, and you have to have a fairly critical method of approaching that to make sure that you don't just go on doing things that aren't going to be helpful. But this guideline is a reasonable source of insight into how to proceed. Next slide, please. The other thing about interventional techniques is that we rarely start with them. They're usually done in the context of managing a patient. So why don't we go on to the next slide. So for example, this is a situation, this is one of the things that I teach about for family physicians who might wish to learn to use some of the peripheral nerve block techniques for their office practice. So you have a patient, for example, who has frequent headache, and it starts at the base of their skull and it radiates in behind their eyes. That's a fairly classic description of what's called occipital neuralgia. And in this case, the patient had a whiplash kind of injury, and also their job requires that they sit at a desk with their head bent forward a bit for long periods of time doing reading. And they find that when they do that, they start to get pain at the base of their skull. It gets extremely sensitive to touch. If they push over the occipital nerve, that bump at the base of your skull, they get a very characteristic headache. It hurts at the site, but it also shoots in behind and it makes the top of their head hurt. So a patient like that, I would say, look, you may benefit from an occipital nerve block, but first of all, let's think about it. One of the treatments are anti-inflammatory drugs. We can prescribe that. They can do stretching techniques and relaxation techniques because the muscle tension is a big part of what triggers these sometimes. Ergonomic modifications to the workplace so they don't have to bend forward so much. So if we go to the next slide. If they come back after a while and you discover that they've done all those things and they still have pretty significant headaches, then we start to think about what are the nerve distributions that might be relevant. So this is a description of a variety of peripheral nerves that feed the sensory supply to the face. We'll talk about some of these a little bit later on, the supraorbital and the infraorbital. But you can see that depending on where the pain is, there are a variety of nerves that you might choose from. All of these ones are branches of the trigeminal nerve, one of the cranial nerves. But if we go to the next slide, please, you'll see that at the base of the skull around the back, you can see the identification of the greater occipital nerve, the lesser occipital nerve, and the great auricular nerve. Interestingly enough, some patients will complain of headache that starts in their neck, and they feel very sensitive at the base of their skull, but for some reason they can't figure out their ear hurts as well. And if you look at that picture of the great auricular nerve down in the lower right there, you can see that it feeds the back of the ear and the inside of the ear. And so sometimes injecting that nerve will actually not only help their headache, but their ear pain goes away as well. You can see the technique that might be used here for the occipital nerve block. You basically take a needle and syringe filled with local anesthetic and spread it across the base of the skull so that you capture the different branches of the greater occipital nerve, and you can see where it comes out through that strong piece of muscle there, why muscle tension might actually start to create a headache. You can see with the lesser occipital nerve, it also wraps around the muscle, and tension in that muscle may create some headache problems. And you can see in injecting it how you'll capture branches of both nerves if you inject at the base of the, just above the bump at the base of your head there, or if you come a little bit farther down and you can catch the nerves where they first come out through the muscles. An injection like that takes about 2 or 3 minutes. You clean the skin with alcohol, do the injection, and usually within about 5 minutes, the patient can tell if it's going to make a difference. And they'll say, yes, I feel some numbness, my headache is reduced. And then what we want to do is follow them along for a while and see how long it works. Now look at the next slide, please. Okay, sorry, back up one then. So with this, what I would want to know from a patient that I had done this for is I would send them away. I would warn them that when the freezing wore off, it may actually feel more sore for a day or so. But if I was successful in blocking the nerve that was responsible for the pain and allowing things to relax for a little while, we think that what we're doing is breaking a pain cycle and allowing people to get back to a more normal function with less pain, be able to move their head and neck more easily, relax the muscles. And what I would want to know is that they had at least a couple of weeks and maybe 3 or 4 weeks or longer of significant pain relief. If they did that and then it gradually starts to return, I would consider repeating that nerve block for pain over time, particularly if it allowed them to carry out their work more effectively and to reduce their use of medications, sometimes narcotic painkillers like Percocet and so on, that may promote the headache in another way. If you can get off them by doing nerve blocks and get a bit more relaxation, better sleep, that sort of thing, we can get a decent clinical response. So that's one of the peripheral nerve block options here. The next slide, please. This is a description of how a lumbar epidural steroid injection is carried out. And this may be one of the most common sorts of injections that's done in pain clinics, particularly for back pain. And it's done particularly for back pain where it's not just pain in the back, but you have pain radiating down the leg. And the idea there is that the pain comes from a disc which is pushing out on a nerve. What you see here is the technique. The syringe is on the right-hand side of the slide. You can see it the needle going through the skin. There's ligaments in the back that connect the bones together, the interspinous, the supraspinous ligament, the interspinous ligament, and the ligamentum flavum. And then we do these injections quite slowly because what we're doing is identifying a potential space called the epidural space. You can see it's labeled in yellow, and you can see that there's hardly any yellow on the picture. But what happens is when the needle slides very slowly into that space, the pressure of the injection opens the epidural space up, and medication, usually a steroid, can be injected into the space, and it spreads through the epidural space onto the nerves that are affected by the disc pushing out. Next slide, please. So this is a discussion about the treatment of lumbar disc herniation. And this was kind of an interesting study. It's from about 10 or 11 years ago. But what they did was they compared doing epidural steroid injections with doing surgery, a discectomy. And the idea was to see whether if patients who presented with pain in their back with radiation down the leg, which is a neuropathic kind of pain because it's coming from the injury of the nerve by the disc, if they did better if you put steroids in, because that's a pretty simple procedure. It takes about 15 or 20 minutes, very quick recovery time. And if it's effective, how does that compare to doing a surgical procedure, taking out the disc so that the disc is removed from its place, pressing on the nerve? Next slide, please. What they discovered was that so they began by randomizing patients to either have an epidural steroid injection or be randomized to surgery. Some patients who were randomized to epidural steroid injection decided they didn't want to do that. They chose surgery. Some patients who were randomized to surgery chose to have epidural steroid injections first. But the conclusion was that if an epidural steroid injection was done, and it worked, by which they meant was it effective in reducing pain, then approximately 50% of patients who were treated with that went on to not require surgery, and they improved in terms of pain, and they didn't have any complications. Next slide, please. This particular discussion now is about spinal cord injuries. Now, spinal cord injuries are a particularly serious, severe sort of neuropathic pain. They're often associated with paralysis as well as pain. And you can see here, this is a list of why people have pain after they have a spinal cord injury. And you'll see that some of it is what's referred to as nociceptive or somatic pain. So that's where the skeleton, the bones, the joints, the muscles are injured, or they're inflamed, or they're unstable. Bones which are broken and don't heal properly and remain unstable are quite painful. Muscle spasm also causes pain. Overuse syndrome. So if you can't use one part of your body, you use another one, and it becomes painful itself. Sometimes in spinal cord injury, you get other problems. With respect to the neuropathic problems, though, you get different kinds of things. At the level of the spinal cord injury and below, you get pain that comes from either pressure on the spinal cord. You get pressure that comes from what's called syringomyelia, which is an expanding core of the spinal cord. The spinal cord trauma itself, or loss of circulation to the cord, and there's what's called a transitional zone, which is where the cord hasn't been completely injured, but is somewhat injured. It's a bit like angina in the heart before you have a heart attack. And then you have both spinal cord and nerve root trauma, the so-called double lesion syndrome. And then you get what amounts to a phantom kind of pain below the level of the injury. So even though you can't feel your legs or your buttocks or your arms, wherever the spinal cord injury was, you start to perceive pain there. Next slide, please. And there are a variety of ways to try to treat it. As you can see here, trying to treat spinal cord pain depends on whether or not you can identify the problem. But in terms of treating the neuropathic parts, sometimes you simply can't treat it, and you need to use psychological therapies or rehabilitation types of treatment to try to improve function and deal with the side effects of having pain. Sometimes you can, in fact, treat the pain. So you see things like using intravenous lidocaine or a drug called gabapentin or pregabalin. Those are marketed as, pregabalin is Lyrica, and gabapentin has been out so long I've forgotten what its trade name is. Also tricyclic antidepressants. or drugs like ketamine, amitriptyline, nortriptyline, the anti-epileptic drugs like sodium valproate or lamotrigine, different antidepressants, intrathecal drugs, and we'll talk a little bit about delivering drugs into the fluid around the spinal cord. That's the intrathecal technique. You can use narcotics, you can mix it with clonidine, or you can use baclofen. And then you can also try spinal cord stimulation or things like deep brain stimulation and motor cortex stimulation. The lesioning techniques, where you actually injure the cord more to try to block the pain, are not very effective in situations where the patient lives for a long time, because over 6 to 12 or 18 months the injured nerve tends to make some sort of recovery, and often you get more neuropathic pain following that. In certain cases with cancer pain, though, where the disease is progressing quickly, there may be a justification for doing so-called damaging or destructive techniques to nerves or the spinal cord to try to stop the pain. So these are some of the situations in spinal cord injury where you might use an interventional technique like an intravenous lidocaine or an intravenous ketamine or spinal cord stimulation or intrathecal drug delivery systems. Next slide, please. Back up one. Jumped. I'm going to tell you, this is a story of a patient that I had a few years ago. He had had a bladder cancer which was treated, and then about 2 years later the bladder cancer came back, and it was quite complicated and quite progressive. It was pressing on not just nerves but other structures in the pelvis, and he had a terrible amount of pain which could not be controlled with oral painkillers, and switched to intravenous painkillers, and they worked for a while, and eventually they didn't. And they were very high doses of intravenous Dilaudid, along with oral methadone and gabapentin and other medications, and he was just in tremendous pain. Next slide, please. We put in an intrathecal drug delivery system, and we started out just using a narcotic, hydromorphone or Dilaudid, and he still had quite a bit of pain, and we attributed that to the fact that a fair bit of the pain was coming from compression on nerves, neuropathic type of pain. So we added a small amount of a local anesthetic, bupivacaine or Marcaine, to the mixture in the pump, and then we got very much better pain control. And it seems that bathing nerves in a very low concentration of a local anesthetic, not enough to block the nerve completely, so this gentleman was still able to move his legs and control his bowel and bladder, but his pain control improved dramatically. And we'll go on to the next slide. We'll show a few pictures of how this is done. So again, we look at a picture of the spinal column and the spinal cord. You can see how the spinal cord comes partway down the back, but about the second lumbar vertebrae, the spinal cord stops, but the sac around the spinal cord continues with a number of loose nerves in it, filled with fluid, the intrathecal fluid or the spinal fluid. And it's possible to, using a technique similar to the technique I showed you for the epidural steroid injection, to insert a catheter into that fluid and then slide it up inside the fluid until it gets to the part of the spinal cord that corresponds to the nerve level of where the pain is. So in this case, the gentleman's pain was in his pelvis, which is innervated by the lower thoracic levels in T10, T11 of the nerves that then go into the abdomen and the pelvis and supply that area of the body with nerve sensation. So we put a catheter in that slipped up to that level, and that's how we infused the medication. Next slide, please. The catheter then comes out the skin and is tunneled around under the skin and brought around to the front, and in the underneath the skin of the abdomen we put a pump that has a reservoir in it, or you can simply put an access port and have an external pump depending on what sort of resources you have available. But you can see that it's not a particularly invasive procedure in the sense that there's no big surgical incisions. The incision for the pump or the port at the front is about 3 inches long, and the skin heals over, and if you have to access it to refill the pump, it's just a case of putting a needle through the skin into the pump. Next slide, please. This is a side view. You can see where the pump sits. The catheter slides around the back into the spinal column, up the spinal fluid, and sits inside the sac around the spinal cord. Next slide, please. And this is simply an actual live picture of how we go about inserting the needle into the cerebrospinal fluid, and then through this hollow needle we slide the catheter and then make a little nick in the skin to tunnel it under the skin. Next slide, please. And you see the needle goes into the fluid. Actually, sorry, in this case the needle goes into the epidural space. We put a little bit of fluid in there. The same that's the technique that would be used if we were doing an epidural steroid injection. We would go a little bit further through that line labeled dura and go into the fluid around the spinal cord, and then we would put the catheter in through the hollow needle. Next slide, please. And one more slide. So we talk a little bit about the recommendations for when we do these things. So a spinal cord stimulator, for example, is put in exactly the same way as one of the infusion pumps or the epidural steroid injection, except that instead of putting medication into the epidural space or a catheter into the spinal fluid, we stop in the epidural space and then slide an electrode into the epidural space up to a certain level that corresponds to where the pain is. And that's referred to as putting in a spinal cord stimulator. The stimulator then comes out and is attached to a impulse generator, which again is implanted under the skin, and it's controlled by a little magnetic wand that's held by the patient. They can adjust the strength of the stimulation, or the frequency, or the type of the stimulation. They can turn it completely off for a while or turn it back on. So one of the things that that's a fairly invasive procedure, particularly for people who've already had back surgery. And so, there's a need to have good indications for doing it. So there's a neuropathic pain problem called failed back surgery syndrome. Basically, that refers to a patient who's had back surgery, but rather than fixing the pain, they continue to have pain, and it often has neuropathic characteristics. It's burning, it radiates down the nerve roots, down the legs, and one of the strategies for treating it is to put in a spinal cord stimulator. If it hasn't responded to conservative treatments like physiotherapy, stretching programs, use of medications like Lyrica, or Neurontin is the trade name for gabapentin, or tricyclic antidepressants, or even narcotic painkillers. If it hasn't responded to that, there is a good reason to try a spinal cord stimulator. And in this case, there is reason to believe, the evidence quality is considered good. There's moderate certainty, which refers to the fact that there are some difficulties in interpreting some of the trials, and it's a grade B recommendation, which means that there's you need to proceed carefully with your decision to do these things. But it's a reasonable recommendation that if you have somebody who's failed with other strategies and they continue to have back pain following surgery, which is really having a big impact on their life, it's reasonable to try a spinal cord stimulator and see if you can reduce some of that pain. One of the other indications is what's called complex regional pain syndrome, which is a very unusual neuropathic pain which may follow an injury, it may follow a nerve injury, or another injury which doesn't specifically injure a nerve. But it's characterized by extreme sensitivity. It most often occurs affecting the lower leg or the forearm and the hand. Extreme sensitivity, often temperature sensitivity. The hand may be extremely cold and sweaty. Hair growth is often affected. Bone density can become diminished over time. And that's one of the indications, again, for use of a spinal cord stimulator. There is evidence that it improves pain control, and by improving pain control leads to improved function. Next slide, please. Patients who've had nerve injuries, peripheral nerve injuries or brachial plexopathy, which basically refers to the nerves that leave the neck and supply the arm, and they form a plexus or a group of nerves, and it's called the brachial plexus because that's how you describe the nerves supplying the upper body. If they cannot be fixed surgically, if there's not an injury that can be repaired or some sort of entrapment syndrome that can be fixed, and if they have not responded to physiotherapy, to medication therapy, there is some evidence that spinal cord stimulation may be helpful. The evidence is not as good as it is for complex regional pain syndrome or failed back surgery syndrome, but it may be worthwhile. And the other thing we don't really talk about here are implanting stimulators right along a peripheral nerve or into the brachial plexus. And one of the reasons we don't talk about it, and there aren't good recommendations, is because there haven't been enough well-designed trials to say that doing things like that is more effective than just leaving it alone. Next slide, please. Some other neuropathic pain syndromes with respect to spinal cord stimulators, and sorry, I just mentioned this now, there simply is not enough evidence from well-conducted trials to either recommend it or to suggest that it shouldn't be done. So unless it's in the context of a research trial, it's really the sort of thing that sometimes happens when, if you have access to treatment, someone might try it. These are expensive treatments, and so many healthcare systems don't support their use except for very clearly indicated conditions. In some settings where people have enough money to buy treatment and they choose to pursue it, they may do that, but it's not something that's generally recommended now, not because it doesn't work, but simply because there isn't enough information to say whether it does or doesn't work. Next slide, please. Intravenous lidocaine, this is a technique that's typically delivered in a clinic setting. Patients with neuropathic pain who haven't responded to other treatments can come into the clinic and be delivered. Typically we'll deliver this treatment over about 45 minutes. We'll start an intravenous and run the lidocaine in. Lidocaine is a local anesthetic. It can be used by injection to do suturing, for example, if you cut yourself, or it can be used for surgical anesthesia for peripheral surgeries. We used to use it for controlling irregular heartbeats in the cardiac care unit. It's been replaced by other drugs now. But it does have effect on the nerves. It seems to have an effect to stabilize their function a little bit. And so there is some reasonable evidence to suggest that in patients with neuropathic pain, a treatment of intravenous lidocaine may supply relief. And if it lasts long enough, if it lasts for a month, for example, it may be reasonable to have repeated treatments over time to try to obtain some pain relief. Next slide, please. Intravenous bisphosphonates is another strategy which can be used for complex regional pain syndrome. Again, there is some evidence that it's beneficial and it may provide pain relief lasting more than a month. That becomes a bit of a big deal because a lot of times these conditions like complex regional pain syndrome don't respond to any sort of treatment. So treatments that can give you a month's relief may allow you to greatly improve your function while your pain is better controlled. Next slide, please. Intravenous ketamine. Ketamine is an anesthetic, an analgesic agent. It does have quite high abuse risk, and it's not absorbed well orally, so it's rarely, if ever, used on an outpatient setting because there's no good way, in patients who are in the community. We do bring patients into the pain clinic sometime to try an intravenous ketamine infusion for some neuropathic pain problems. And again, there's some evidence that it works. It may not provide long-term benefit, but it may be done in a clinic setting where you combine it with physiotherapy and try to recapture some function and strength while you have good pain control in order to regain function if the pain problem is preventing people from exercising and getting good functional recovery. Next slide, please. There are some other blocks that you can do. There's an entity called neuralgia paresthetica, which occurs, next slide, which occurs, that's it, thank you. There's an entity called neuralgia paresthetica, which occurs in the nerve of the thigh. Sorry about my spelling there. It happens sometimes in pregnancy when the abdomen extends over the top of the pelvis because it squeezes this cutaneous nerve where it leaves the pelvis and comes over the iliac crest, the bone at the front of the pelvis. Or also belts that are too tight, or you see it in men with large bellies who wear tight belts, or in seatbelt injuries sometimes you'll get it, where the patient complains of burning in the thigh and injecting the nerve significantly improves the pain. Also intercostal neuralgias, the nerve running between the ribs. If you have surgery on the chest, sometimes that nerve is injured, or if you fracture your rib, sometimes you injure the nerve. And injecting it can have a really dramatic effect in improving pain control, allowing people to breathe properly, or just permitting them to move properly without so much pain from the nerve injury. Next slide. I think we have a couple of slides of where these nerves run. Yeah. So on the picture here, you see on the left-hand side where the lateral femoral cutaneous nerve runs. You see it coming out of the pelvis over the iliac muscle, over the iliac crest, the iliac spine there. And it goes under the inguinal ligament. So that's another time it can be injured if somebody has an injury to their inguinal ligament from a twist or a stretch or a fall. And you can see where the nerve runs and how it might be injected. Next slide, please. Similarly, this is where the intercostal nerve runs. This is a section of the chest wall, and you can see how it starts close to the back. It's actually a continuation of the nerve root, and it runs along beneath the rib, comes out in a couple of places to supply the skin and the muscle. And if you go to the next slide, you should be one other slide just before that, I hope. No, maybe I didn't put it in. Anyway, you can inject it by sliding a needle very carefully between the ribs. You have to be careful not to go too deep because, of course, the lung is beneath the chest wall, and you want to avoid putting holes in the lung and causing pneumothorax. But it's a nerve block that can be done with a really good effect for neuropathic pain from nerve injuries in the ribs. Next slide. So when we talk about any kind of interventional techniques, one of the things you have to keep in mind is that there are adverse events or complications. It depends on the blocks. They're very common things are people are just anxious about the blocks. The injections often hurt, and you can have what's called a vasovagal event, or basically a fainting spell, which is a combination of the effect of the anxiety and the pain. So the way to avoid that, obviously, is to have people sitting down when they have the injections or lying down, and make sure that they rest a little bit while they're after they have the injection. You can get delayed complications. Sometimes the local anesthetic effect may wear off, and they may suddenly experience pain, and they'll have a fainting episode on the way home. If we're using steroids, patients with diabetes can have high blood sugar. Anybody can get high blood pressure or fluid retention. And if you use a lot of steroids over time, and there are guidelines about this, and we advise against it, you can get easy bruising, or you can have patients who are subject to infection because of the effects of the steroid doses. Next slide, please. The other thing is, depending on the kind of nerve block or the complexity of it, there are technical problems that can occur. You saw, from the description of how we do intraspinal injections, for example, or epidural steroid injections, that we're putting needles close to major nerves, we're putting needles close to the spinal cord itself, and so you can injure nerves, you can injure the spinal cord. You can have infections if you don't pay very close attention to good sterile technique when you do these blocks. You can have bleeding from the injection itself or as a complication if, as I said earlier, the patient may be on a blood thinner. If you have bleeding in an enclosed space, such as around the spinal cord, you can have further nerve injury and, as I said, maybe even a spinal cord injury and paralysis. And the other problem is that when you put needles near nerves, sometimes you injure the nerve and you actually make the pain worse. So there's a real technical challenge to making sure that we do the blocks appropriately. Next slide, please. Some people talk about doing sedation for nerve blocks. On the first step, when you first do an injection, part of what you want to find out is how much difference the injection itself makes for the pain. And so we'll often do diagnostic injections without any sedation at all, even though it may be painful to have the needle, because we don't want to confuse the situation. Once we give a sedative, and the sedatives are often things like Valium or morphine or a combination of the two, that will also make the pain better, and it becomes very difficult to determine whether the pain got better because of the sedation or the pain got better because of the injection. In some cases, if you go on from doing a diagnostic injection of a nerve to doing a more advanced thing like a radiofrequency rhizotomy where you use electrical current to damage the nerve a bit so that it functions differently, in that case, because that can be painful, once we've decided by the diagnostic injection that this is what we're going to do, we may then go ahead and offer sedation so that the actual treatment procedure is not so painful. Next slide. That just about does it. I saw at least one question turn up there. So what I'm going to do is turn it over now to Jillian and Dr. Levinson, and they're going to feed me some questions, and I will answer them. We've got about 15
Thank you. Thank you very much, Dr. Buckley. That was excellent. And yes, we've got some great questions coming in. So here's one of the questions. I'll take them in order. It basically says, at one point you had mentioned adding an anesthetic, I think a local anesthetic, to a steroid for a type of nerve compression pain. That was with respect to a cancer patient. Is that type of addition of the anesthetic to the steroid, is that ever done in the setting of discogenic related compression problems or injections to or interventions to help with disc compression?
Yes, the short answer is yes. The reason, there's several reasons for it. So in disc protrusions or disc distension, or where you have the fluid from inside the disc leaking out and causing inflammation around the nerve, the local anesthetic does two purposes. You saw from the description of, or from the picture describing the epidural steroid injection technique, that we put the needle close to but not through the dura. It's very important to confirm that we're not inside the dura before we put the steroid in, because the steroid can be extremely irritating inside the spinal cord. In fact, it can cause a number of problems itself, including something called arachnoiditis, which is a very painful inflammation of the tissues surrounding the spinal cord. So we want to be sure that we don't have the tip of the needle in the dura or in the cerebrospinal fluid before we put the steroid in. So when we think we're in the correct place, we then put in 1 or 2 cc's, a small volume of local anesthetic, and we ask the patient to tell us if they get sudden numbness. If we're in the epidural space, it won't have any effect at all in terms of numbness. It can serve to reduce some of the pain coming from the nerve, the nerve where it's irritated, but it won't make them suddenly numb. And so once we know that they're not suddenly numb, we know that we're not in the dura and we can safely inject the steroid. We then inject the steroid, and usually we make in the epidural steroid setting, we inject a fair volume, usually about 5 or 10 cc's of diluted steroid, and that serves to spread it around, and it also spreads the local anesthetic, and that provides a little bit of pain control from the local anesthetic, but the real effect there comes from the steroid, and it takes 2 to 3 days to work, to reduce the swelling around the nerve, to reduce the inflammation. The other place where we'll use some local anesthetic, I didn't describe the facet block or the medial branch block, but when those are done, that's an X-ray guided technique which brings the tip of the needle very close to not only other nerves, but also the cerebrospinal fluid. Or if you're going to proceed with the radiofrequency lesioning, you want to freeze the area first with local anesthetic, or you want to use the local anesthetic again to demonstrate that the needle's in the correct place before you go ahead and inject steroid or do a radiofrequency. So the short answer is yes, we do often use local anesthetic mixed with steroid, and we'll often do that on a peripheral nerve injection as well. We'll inject local anesthetic, and this time it's the reverse. We may add steroid because there is some belief that it makes the effect last a little bit longer. Again, you have to be careful how much steroid you give patients over time, so we restrict the total dose.
Great. Well, we've got a couple more questions, so I want to try and make sure we can include everyone's questions. So another one here related to kind of nerve entrapment in the groin area following hernia surgery. So it sounds like in this scenario there was an initial surgery and then 2 follow-up surgeries to relieve pain, and unfortunately a large amount of scar tissue developed and has trapped the nerves in the groin. Are there any kinds of interventional techniques that come to mind for this type of nerve entrapment situation? Yes,
that's actually a common one. I nearly threw the slide in, but I decided not to. Obviously, I should have. That's another technique. There's 2 specific nerves that are often entrapped in hernia surgery, the ilioinguinal nerves and the iliohypogastric nerve. And sometimes those entrapments will also end up affecting the genitofemoral nerve, which often causes pain radiating down into the groin, or in case of men who have most of the hernia surgeries, into the testicles. And it's quite painful. You can inject those nerves, and we often inject a combination of local anesthetic and steroid in the belief that the steroid may soften the scar. But certainly you can reduce that pain somewhat. Sometimes it's necessary to have a plastic surgeon go back and explore the area very carefully to try to identify the nerve and perhaps release it from some scarring. The difficulty there is that if it got trapped in scarring once, there's no reason it won't get trapped again. Some of the other techniques that may help there are TENS therapy, for example. But certainly that's an area where we do use interventional techniques. It is challenging, but it's a difficult problem because you're always using those abdominal muscles, and if the nerve is trapped in the scar, you're always irritated.
So here's another good general question, though there is, the question is, how can we find out where exactly types of techniques, interventional techniques, are done? Now, the question was sort of what facilities in Ontario, but I think given that there's a national audience, are these types of interventional techniques usually reserved to kind of university-related pain clinics, or is there a way to find out where interventional techniques are done?
It depends partly on the specific technique, but one of the resources you can go to, there's a group called the Canadian Pain Coalition, which is a patient group. It's affiliated with the Canadian Pain Society, but it's developed by and for patients. They maintain a website which has a variety of information on it, but one of the pieces of information they do have is a list of pain clinics and pain treatment facilities across the country. Now, some of the more advanced ones, the ones that require more resources, X-ray guidance or CT guidance, for example, those will typically be done in hospitals and often in university pain treatment centers. Some of the other ones I described, like the occipital nerve blocks or some of the other peripheral nerve blocks, They may be done in a variety of community pain clinics. In Ontario, there's two commercial clinics that I know of. One is called the AIM Centers for Pain Management, CPM clinics, and the other is Pain Care Centers, PCC. Both of those groups have several clinics in different parts of Ontario, but the Canadian Pain Coalition actually maintains a national listing of pain clinics.
In the chat panel, Jill has posted the link to the Canadian Pain Coalition URL. So if those of you can check that out, the direct location to the URL with the clinic locations. We've got time for one last question. This person thanks you for a great talk, and the question is about brachial plexopathy. And what is the evidence for device therapy in relation to brachial plexopathy? It appears the examples you cited before were really more for the low back pain. Can you speak to that and maybe also speak towards any role for sympathectomy in brachial plexopathy?
Okay, yeah, thanks very much. The brachial plexopathy is one of those areas where we haven't been very good about consistently generating good clinical trials on the topic, but partly because it doesn't occur that frequently, although for the folks that have it, it's a big problem. Partly because I think clinics, we haven't gotten very systematic about making sure that we go through a process of good clinical trials when we have some of these complicated pain problems. The one reference I put in there comes from the pain guideline, the Interventional Pain Guideline, which talked about using a spinal cord stimulator for brachial plexopathy. And the conclusion there was that it wasn't entirely clear that it was beneficial. Other device therapy, I'm presuming you mean things like directly implanted nerve stimulators, so nerve stimulators like a spinal cord system but implanted directly onto the brachial plexus nerves. And that's one of those areas where we simply don't have enough information. In some areas where either as a result of a research trial or in the United States, basically where it's a market-driven system, if people have these problems, there will be clinics that provide the service. The problem there is that the clinical trial follow-up often is not great, and it's difficult to compare it to other strategies. So it's very hard to come to a conclusion. And with respect to sympathectomy is useful in interrupting symptoms that come from sympathetic overactivity. So if temperature changes or sweating and are problems along with the hypersensitivity or pain, then there may be a role for sympathectomy, but it's not entirely clear.
I think we'll because of the time, we should probably wrap up now. There were a couple of questions that we couldn't get to, so I'll apologize about that. And also, it is a balancing act in providing kind of education and information about the any topic in the webinars and on the website, between making it educationally useful and broad without necessarily providing specific individual kind of patient health information or patient advice. So some questions may begin to divert towards specific clinical situations, and we do need to kind of walk a line around providing broad speaking evidence-based information. So I want to thank Dr. Buckley for a truly informative webinar. There's a lot of different techniques and a lot of different neuropathic pain conditions, so it's very hard to cover so much. So you really did cover a ton of breadth today in terms of different conditions, different techniques, and still more out there that we're coming up with as well, even related to sympathectomies and TENS and other types of interventions. Please do fill out the evaluation form about this webinar and also topics that you would like to have expert webinars on in the future. And please also check out Pain painhq.ca. Give us feedback. The website is there for you. We have a ton of resources of different kinds. Rate the resources. Help us make the site the best it can be to provide you with evidence-informed information about neuropathic pain. So with that, I'll thank Dr. Buckley again. I will thank all of you for joining us, and for Jill for helping to organize the webinar today. Thanks, and we'll see you online.